We find Vecna, we end this once and for all, together.
On November 26th.
We have a plan. It's a bit insane. Everyone in?
He knows where we are.
Watch out!
Get ready for one last adventure.
We stay true to ourselves. Stay true to our friends, no matter the cost.
Found you. Stranger Things, the final season, begins November 26th, only on Netflix.
Vaginal dryness is common and completely fixable. And here's more good news. The FDA just dropped the black box warning on vaginal estrogen. What does that mean for you? Stay tuned. Hi everyone, I'm Barbara, and this is Age Better. Today, we're tackling a topic that affects millions of women after menopause, but still doesn't get talked about nearly enough: vaginal dryness. It's more than discomfort. It can lead to pain, UTIs, and a real impact on quality of life. And here's why this conversation matters right now. The FDA just removed the black box warning on certain hormone therapies, including topical vaginal estrogen, which is the gold standard treatment for vaginal dryness. This is a major step toward reducing stigma and empowering women to get the care that they need. My guest, Dr. Margaret Nachtigall, reproductive endocrinologist at NYU Langone Health and one of the leading experts on menopause and women's midlife health, will break down why vaginal dryness even happens, what your treatment options are, and why topical estrogen is not only effective, but safer than many people have been led to believe. So if you've been avoiding treatment because of fear or confusion, this episode is your sign to take back control. Okay, everyone, get ready to age better. Dr. Margaret, welcome back to Age Better.
Hi, Barbara. Thank you. Excited to be here.
So you were on just a few weeks ago talking about what you heard in the room when you were at the Menopause Society conference, which was fascinating. And I'll put a link to that episode in the show notes, everyone, just in case you missed it. But today we're talking about a milestone in women's health. Just a couple of weeks ago, the FDA took the black box warning off of estrogen, meaning hormone therapy, topical vaginal estrogen therapy. So we're going to be talking about all of that. So this is really big news. And of course, I immediately contacted you and said, we have to have an episode about this. But let's start from the very beginning. Just kind of refresh our memories. Like, why was there a black box warning put on estrogen anyway?
Right, in the first place. So really what happened is, and we've talked about this a lot, which was the Women's Health Initiative, the WHI, which was, 100,000 over women. And the way that the study was designed, it was to look at the effects of estrogen and progesterone, and of course, estrogen alone, for cardiovascular disease. And in doing so, really, it would be advantageous for the study to not have a confounding variable of hot flushes, because the group that was getting estrogen would have no hot flushes once it got started, and the placebo would continue. And so because of that, the patients were patients of all ages anywhere from the early 50s all the way up into the 80s, which meant that so many women had been 20 years from menopause when they were starting this treatment. And so initially, when the study was started, it was a combined estrogen and progesterone, equine, conjugated equine estrogen with majoxyprogesterone, which are both by mouth, and given continuously to women, compared with a placebo group, which got no hormone therapy at all. And then there was another arm, which were patients had no uterus, and so they got estrogen alone, conjugated equine estrogen alone by mouth. And after 5 years, it looked as though breast cancer rates were increased and cardiovascular disease might be increased as well. And so the study was halted. However, when we look now, and now we're 20 years from this, and there was a lot of publications since that time. And Joanne Manson, who was on the initial paper, came out with the 18-year follow-up of the WHI. And what was observed was that actually the group that got estrogen alone had a decrease in breast cancer and a decrease in cardiovascular disease, better insulin resistance, lower diabetes. The only thing that was slightly increased, and it didn't even reach statistical significance, was blood clots. And we know that oral estrogen does slightly increase blood clots as opposed to transdermal, which we think is much, much less likely to. But the conclusion of the study actually was that conjugated equine estrogen actually had a good effect. And when you give it in the age group, which is close to menopause, we know this, the timing. If you give it within 10 years or start under the age of 60, that it has all of these beneficial effects, or at least it's not harmful. Now, always, even before the WHI, and certainly since the WHI, local estrogen given just to the vagina is almost not even absorbed. It's negligible how much estrogen you get by taking vaginal estrogen. So the fact that there was a black box warning on that really did not make any sense at all. And so now with all of the research on estrogen, on the effects of estrogen, on all aspects, now the FDA reevaluated and removed that warning because given to the right individual, to the person that is starting under the age of 60 or within 10 years of menopause, and you know I always say the sooner the better,
Yes,
right?
yes, you do.
Then actually the risks are low. And therefore, of course, it's individual. And of course, we have to take each person into consideration. But now I think we have patients will feel safer and doctors will feel safer knowing that they don't have this black box warning.
Exactly.
Right?
No, I think that this is really going to open up a lot of new opportunities in the minds of women where, they were a little concerned before in considering, and I'm now thinking specifically about the topical vaginal estrogen therapy, which is not systemic. Local, exactly. And they might have been hesitant. I myself have been on it for going on 20 years. And I've always been incredibly comfortable about it. But let's talk about that. So specifically, that addresses one of the most common health issues and challenges of perimenopause and menopause and postmenopause. And that is vaginal dryness. And that's really what I wanted to focus on today, because the black box has been removed. So great. Let's talk about it. Let's get women even more comfortable with this as an option. What are your thoughts?
Well, I think absolutely. Vaginal dryness is something that happens when there's no longer any estrogen in the body and less or no estrogen is affecting the vaginal tissue. And the vagina is an elastic structure. And so without estrogen, it becomes dry, which is why you call it vaginal dryness. But it doesn't stretch as well. It's less moist. The color actually looks paler. And what happens is the pH of the vagina goes up. And when the pH is elevated, that allows for a different type of bacteria to grow. And you can get overgrowth of bacteria and actually an increase in urinary tract infections. So reversing that, lowering the pH, bringing back the moisture, bringing back the right kind of bacteria, allowing the vagina to stretch normally makes a huge difference, not only in the comfort to decrease the symptoms of vaginal dryness, which can be itching or burning, but also decreasing the likelihood of developing urinary tract infections. So it's actually beneficial to have some estrogen. And the doses that we use for treatment when estrogen is being used locally in the vagina are extremely, extremely low. We're talking about 10 micrograms twice a week. So it's just such a low, low dose. And for systemic estrogen, you have to balance that with some progesterone for patients that have a uterus. However, For local or vaginal estrogen, you don't need any progesterone, and you can start at any time. You can be 70, you can be 80 and start estrogen then. You don't have to be within 10 years of menopause. So this is a very easy way to restore the pH to the vagina. I mean, we have other ways of treating as well, but for the estrogen, this is a really good way for a lot of women.
And you think also that the black box removal, the black box warning removal is really going to help women and doctors, as you pointed out, feel more comfortable with this. But you're right there.
I think so.
I think so too. I really, really do, because I've talked to women and they've been very hesitant to have anything to do with estrogen treatment and therapy. So I think this is really going to make people more comfortable.
I do. And I think doctors will feel more comfortable prescribing estrogen. Also, there's a lot more awareness now. The fact that this hit the media and people are talking about it allows women to feel comfortable.
Oh, yeah. I mean, there's really quite a group of very loud voices out there who really, I think, were quite instrumental in helping to get this through the FDA. Don't you think?
Yes, I do.
All of us are more comfortable discussing it, and that's a really positive thing for women and women's health. But this is not the only treatment available. And the good news, too, is that this is treatable. That's really important. I always want to make sure that we convey to our listeners that this is a health condition connected to menopause and drops in estrogen that really is treatable. And there are a lot of options. So let's talk about some of the maybe non-hormonal options.
And I think it's very reasonable. Well, first of all, everyone is different, has different symptoms, presentations. I think it's very reasonable to consider an over-the-counter or non-hormonal option prior to initiating estrogen locally. So there are many options. There are agents that lower the pH. There are hyaluronic acid compounds that are very effective in restoring the epithelium back to where it was before. And there are different ways. There's hyaluronic creams. There are hyaluronic suppositories that can be used. And these can be inserted into the vagina. Depending on the individual, someone might want to do this 3 times a week, 4 times a week, some people even daily. And I've even used this in conjunction with estrogen using the tiny doses. And I think that's a great option.
That's exactly what I do.
I probably told you that.
Yep. I use my local vaginal estrogen therapy for 20 years.
Twice a week.
But then I also use the over-the-counter. In this case, I use Reverie.
I love Reverie.
By Bonafide. You recommended it to me.
I think they're great. They have 2 options. They have a version that is just hyaluronic acid, comes in a small suppository that's very easy to use, or you can use the hyaluronic acid with almond oil. That is also, they call it Reverie Plus. So that's a great option. There are other brands as well. There's GynoFit. There's Hyalo GYN. There are other ones that can be found in the pharmacy. So there are other ones. There's a cream. There's a Via cream that some people use. I happen to like the suppositories as well, but lots of different options for the hyaluronic acid option. And then there are moisturizers. There are moisturizers that are going to bring the moisture back into the vagina. And so those are good options for people. Replens is one of those that people like. And those are usually used 2 or 3 times a week, sometimes 4 times a week as well. There are aloe-based moisturizers. There are polycarbophyll moisturizers. Some people actually use vitamin D. Some people use, vaginal lubricants. In addition...
What is the difference? Tell us, what is the difference between a lubricant and a moisturizer?
Right. So a lubricant is something that you would use prior or during intercourse. And so that is something that's going to work at the moment to make the vagina, more slippery, if you will, easier to use. And so that would be they have water-based and silicone-based lubricants. As to moisturizers, which you can just use regularly. It doesn't have to be situation-based. And the lubricants, the water-based ones, are one option, silicone-based. And some people actually use either almond oil or coconut oil. And so this is another option.
Yes, I have a very dear friend who swears by coconut oil.
Absolutely. And so these are other options for people. In addition, pelvic floor therapy can be helpful. There are pelvic floor therapists, which can aid in this. There are laser therapies, which are non-hormonal. These are not FDA approved yet, but there are different lasers that can be used for people who cannot take estrogen. And then, of course, there are the hormonal options, the estrogen being one, and then also a DHEA, which is a suppository that people use, and that's a daily insertion, which is also a great option for people and doesn't have any estrogen in it.
Right. And for anyone considering treatment, I made some notes here about how should they think about different forms? I mean, you can get a cream, a tablet, even a ring. And this is really, I guess, the hormonal treatment, but also
So that
the
would be,
non-hormonal.
well, the non-hormonal, I don't know of any rings.
That's
not
true.
hormonal. But for
Right.
the non-hormonal, just as you mentioned, there are creams and there are
There are
suppositories.
tablets, suppositories, which is actually, what I use.
And then for the hormonal options, when we're talking about estrogen, there come in a ring. A ring is a great option. It's a slow release of estrogen. That's tiny doses that the ring is inserted into the vagina and it stays for 3 months. You can take it out and wash it if you want in between, or you can just leave it in, whatever you prefer. And every 3 months you change it. So it's very easy. You don't have to keep inserting tablets or suppositories. And then there are tablets, as you mentioned, that have applicators that you can insert these tiny little dose, 10
Teeny
micrograms of estrogen that you use usually twice a week. Or you can also use a cream. And the cream can be inserted into the vagina. Sometimes I'll use the tablets inside for people, and then a little bit of the vaginal cream on the outside for the outermost, the entry into the vagina. And that can be a great combination. You need really low doses, doesn't get absorbed, a wonderful way to do it. There are some soft gel inserts that you can use. Usually people do those without even an applicator. And those also are twice a week, very effective. People really like those as well. And so these are the estrogen ones. And then remember, you don't need any progesterone with this. So it's just the estrogen, unless you have systemic treatment. But if you're doing just the inserts, then you don't need that.
So hormone therapy, that's, say a patch, if that's the delivery system, the systemic hormone therapy, does that help directly with vaginal dryness as well?
Absolutely. Does a fantastic job with vaginal dryness, depending on the dose. Sometimes people's doses are so low that in addition, they use the vaginal inserts as well. I have people that are on patches, on pills, and using vaginal estrogen. And some people, the patch or the pill is enough and they don't need it. It really depends on the person, but you can certainly add it because the dose of estrogen that you're adding vaginally is negligible to nothing. So the other thing that we have is a DHEA tablet that you can insert vaginally nightly, and that's really good for people that also have pain on intercourse. That really mitigates that. It also seems to help with libido. So that's another good option. We do have a tablet for people who absolutely cannot insert anything vaginally. It's osphenamine.
Oh, that's an oral pill?
Ospenafine, yes, it's a pill. It's by mouth.
It's a pill.
The one thing I caution about that is that, and it's not estrogen, it's a selective estrogen receptor modulator. So in some parts of the body, it acts like estrogen, and in other parts, anti-estrogen. Fantastic for vaginal dryness. However, it does slightly increase blood clotting. So I don't like to use it in anyone that has a high likelihood of blood clotting. There is a tablet that's over the counter called Femoral, which is no estrogen at all. It's an extract from soy, and that happens to been shown to also decrease vaginal dryness or increase the comfort vaginally. So that's another oral thing that some people can do.
Yeah. I think the big thing here is that the big message is that there are so many options.
Right.
And the fact that,
you
know,
can combine them.
You can, as I do, as we talked about. And I even use coconut oil too. I forgot about, I throw that in to the mix. Like, why not?
I do want to talk about, though, and bring up the people who can't use it because,
yes,
there
please.
are some people that honestly really cannot have even that amount of estrogen, even though it's negligible and even though it's so small. So most people that have had breast cancer can still use vaginal estrogen. And most of the breast oncologists and most of the breast surgeons feel that it is okay. And of course, it should always be run by your doctor to make sure that it is okay with them. But most people who have had just breast cancer, it's okay. However, there are some people who have had breast cancer or other estrogen receptor tumors, because there are other tumors that have estrogen receptors that are not breast cancer. We have other kinds of tumors. But if you have an estrogen receptor positive tumor and are on an aromatase inhibitor, that's an agent that blocks the conversion of testosterone in the body to estrogen, even the tiny amount that is in vaginal estrogen is usually not advised. So people that are on aromatase inhibitors probably should really focus on the non-hormonal options rather than the hormonal ones. And I feel like most people that have had breast cancer should definitely start with the over-the-counter or the non-hormonal options first, and then go to the estrogen ones if necessary. But I do feel that there's been a couple of very good studies showing that there really was not a difference in recurrence rate in people who had had breast cancer, whether they were using vaginal estrogen or they weren't. So in most cases, doctors will feel comfortable with it, but it's an individual decision.
And I think then also another message that you always leave with us every time you're on the show is that this is very personalized, of course,
Sure.
Individualized medicine, but you have to have a good discussion with your own trusted healthcare
Absolutely.
provider.
Always.
Because in partnership, then together you'll decide what are the best treatments for you,
Right.
given everything, or given all the details of your own personal health history.
Right. And of course, try to stay healthy and eat well and hydrate and all the other good things. And there are some, I think, medications that can increase the likelihood of vaginal dryness, some antihistamines, other things.
And just aging. Aging, not everybody will experience this, of course, but it is also a part of the aging process, I think, the older you get.
Most people do at some point. Most women with vaginas do end up having vaginal dryness if they're not treating it in some way. Just the longer you are without estrogen, the more likely it is to occur. And the symptoms, again, would be itching, burning.
Uncomfortable
People
sex.
tell me, exactly, pain
Pain
with
when you're
any
urinating.
kind of.
Yep, it's
But
horrible.
the big thing is people say it feels like sandpaper walking. I will say that all of the symptoms that we just discussed are also signs and symptoms of either vaginal infections or urinary tract infections. So it is important to rule out an infection and not just assume that it's vaginal dryness. And I think that's an important factor.
So before I let you go, what are your 3 biggest takeaways from this conversation today?
I think the big takeaways are, 1, the FDA has removed the black box warning, and certainly on vaginal estrogen compounds, that there are non-hormonal as well as hormonal options for treatment of the dryness that occurs when estrogen is no longer present in the vagina, and that the treatments are extremely well tolerated. So estrogen and non-estrogen, hormonal and non-hormonal options, and to go ahead and ask your healthcare provider about what options would be best for you. And then, of course, the small group of people with breast cancer who have aromatase inhibitors shouldn't take it. But overall, a great, I think, area now where we are. Oh, and that when it's given locally into the vagina, you don't need progesterone. And I think that is something that a lot of people don't know. And they think that they have. I just had a patient today who thought that she had to take progesterone with her vaginal estrogen, and you do not. So
You do
that's
not.
big. Mhm.
Yep. All right. Well, thank you so much for joining in. And everyone,
So good to be with you.
thank you so much for tuning in. Talk to you next week.
Bye.
Thanks for tuning in, everyone. If you enjoyed this episode of Age Better Podcast, please do a few things. First, share it with all your friends and family. Then, subscribe to Age Better wherever you listen to podcasts, including YouTube, so you never miss a single episode. Finally, if you have ideas for topics you want me to cover in a future episode of Age Better, send an email to agebetterpodcast@gmail.com or reach out to me on social media. Until next time, remember this. We can't control getting older, but we can control how we do it. Talk to you soon. Age Better Podcast is a proud member of the Sound Advice Network. Sound Advice, women's voices amplified.